Hi, my name is Sydney Hadley. I am a first-year internal medicine resident at Advocate Christ Medical Center. Today, I will be presenting a case about an ACTH producing pituitary adenoma found after transsphenoidal resection of a meningioma. So, as it is known, ACTH-dependent Cushing's disease is a condition characterized by pituitary hypersecretion of ACTH, leading to adrenal cortisol upregulation. Along with Cushingoid features, hypercortisolism also has long-term complications, notably metabolic syndrome, cardiovascular disease, and osteoporosis. The incidence of Cushing's disease is approximately 1 to 2 cases per million. Here, we report a case that describes ACTH-dependent Cushing's disease caused by a pituitary microadenoma in a patient with a history of planum sphenoidal meningioma. This is a 48-year-old female with a past medical history of planum sphenoidal meningioma, status post-transsphenoidal partial resection, central hypothyroidism on levothyroxine, and hypogonadotropic hypogonadism, who presented with worsening truncal obesity and prediabetes. The physical exam was only remarkable for obesity and hyperpigmentation of knuckles. Labs are shown below in the table. Prolactin, TSH, and HGH levels were normal. Her AM cortisol was elevated at 27.2. Her ACTH was significantly elevated to 81.8. Saliva cortisol, which was taken at 11 p.m., was 0.154, which is also elevated. Her cortisol was not suppressed by low-dose dexamethasone test, but was suppressed by high dose at 2.0. This indicated a pituitary source. An MRI of the pituitary was then performed to locate the potential source and was significant for hypoenhancing lesions suspicious for bilateral synchronous pituitary microadenomas. A PET Donate scan was done and showed hypermetabolic meningioma corresponding to the findings of the pituitary MRI and confirmed no other abnormal focal radiotracer uptake. Non-functioning pituitary tumors are common, so to confirm the pituitary source of ACTH prior to surgery, she underwent inferior petrosal sinus sampling, IPSS. This revealed a significantly elevated ACTH secretion from the right microadenoma. Transsphenoidal resection of pituitary tumor was performed. As you can see in Figure 1, this is the cellular region surgical pathology from the resection. Nests of neuroendocrine pituitary cells in a fibrous stroma were shown, in 10x magnification on the left and 40x on the right. In Figure 2, you can see the various stains that were used. On the left is synaptophysin, which was positive, chromogranin in the middle, which was positive, and keratin KM 5.2 on the right, which was positive. The sample was negative for GFAP. Post-pituitary tumor resection AM cortisol was undetectable, and post-pituitary tumor resection ACTH was 5.8. She was then started on hydrocortisone for presumed adrenal insufficiency, post-pituitary lesion resection. No signs of diabetes insipidus were shown after surgery. The patient will follow up with endocrinology for eventual weaning off hydrocortisone. So in conclusion, simultaneous occurrence of pituitary adenoma and meningioma without a history of radiotherapy is extremely rare, with only 49 cases described before 2019. Even more rare is an ACTH secreting pituitary adenoma coexisting with a meningioma. IPSS procedure was performed after MRI in this case to get an even more accurate localization of the source before surgical excision, as it is the best test to differentiate pituitary from ectopic ACTH-dependent Cushing's. In approximately 1 out of 3 patients, remission is not achieved with surgical excision alone, and for this reason, patients need postoperative monitoring and secondary medications to control their symptoms. Thank you for listening and hope you have a great day.